All right, good afternoon, everyone. This is Tracy Morton at the National Rural Health Resource Center, and welcome to the first virtual knowledge group call for the new calendar year. So happy 2019 to everyone. So today's call is about how the Flex programs around the country might be working with the provider-based rural health clinics within your state. And if you aren't working with them, that's okay. It's an opportunity to learn about some ideas about how other programs are working with them currently or are thinking about working with them in the future. And this is particularly timely as you, at some point in time here in the near future, will begin working on writing your competitive application for the Notice of Funding opportunity for the fiscal year 2019 Flex Program Cooperative Agreement, which should be released at any day. So there's certainly an opportunity to not only support the critical access hospitals in your state through the services and activities that are provided via the Flex program, but also to tie in other healthcare providers, including rural health clinics that may or may not be provider-based, or other healthcare entities within the program as well too. So we'll explore a little bit about what that is. I mentioned already, my name is Tracy Morton. I'm the Director of Population Health here at the National Rural Health Resource Center. But one of the major roles that I play here at the center is I'm the Program Manager for the Technical Assistance and Services Center, or TASC, which is a federally funded technical assistance center to support you, the 45 different state Flex programs. So it's really great to have you be part of this call today. If you haven't participated in a virtual knowledge group in the past, we will have a little bit of a webinar-like content to today, but these are really meant to be a discussion opportunity for the Flex programs to share with each other what they're up to and ask questions of one another in really more of a brainstorming type environment. So I encourage you to talk on the call. So you can use the chat box that's on the left side of the screen if you'd like, but also we'd love to hear your voice too. So you can press *2 on your telephone keypad to mute or unmute your line as we move into this. If you are using your computer, we really strongly encourage you to dial into the audio portion of the call via the phone number that's available in the chat box, and not use your computer speakers, as sometimes we get some echo via that. So if you have the opportunity to call into the audio portion, we'd appreciate that. So today, like I said, we're going to be talking about Flex programs supporting provider-based rural health clinics. And what a provider-based rural health clinic means is, yes, there are healthcare providers within that facility, obviously providing that healthcare, doctors and NPs and PAs and nurses and such. But a provider-based rural health clinic means that the provider-based part is actually the critical access hospital either owns or operates the rural health clinic. So that's when you hear provider-based, that means that a CAH is owning or operating that rural health clinic. So today we're going to learn about some of the initiatives a Flex program can take to support a provider-based rural health clinic, particularly kind of dialing in a little bit on activities that support the transition to value. And then you'll hear from your Flex program peers, 3 of them, regarding how they're working to meet some of those needs of provider-based rural health clinics within their states. We'll kind of explore what some of that landscape looks like a bit. So today we'll be touching really on the core competencies for the State Flex Program Excellence, about understanding systems of care, because our work isn't just about hospitals, it's about that whole system of care and tying that all together. We'll, of course, talk a little bit about supporting hospital financial performance, because those provider-based entities at the rural health clinics, not only do they get paid differently, but they also work in tandem with financial performance of the critical access hospitals and supporting that outpatient stream that's really critical to a critical access hospital success in that primary care. So that's what we'll be talking about today. If you're not familiar with the core competencies for State Flex Program Excellence, go to the TASC website, which is ruralcenter.org/TASC, and check out the core competencies there. It's a pretty vital piece of information related to your work in the Flex program. So about what we're going to do today, we'll have some polling questions here at the beginning to hear about, from those on the call here, what the landscape, I guess, if you will, looks like for rural health clinics within your state. Then, as I mentioned, we'll hear from a few of your peers about their experience working with rural health clinics. So joining us today is Michelle Mills from the Colorado State Office of Rural Health, Stacy Rothwell and Rebecca Dobert from the Oregon Office of Rural Health, and then Nick Galvez from the North Carolina Office of Rural Health. So they'll kind of share a little bit about what it is that they're up to in their states, and then we'll kind of engage in a couple more polling questions and participate in some question and answer that you may have for any of the states to present or for each other, and then talk a little bit more about what your plans might be to support the needs that you're hearing from your rural health clinics in your state and how you might fold that into your FLEX program work in the future. So that is the plan for today. And Shannon's going to help as we move through the call today to pull up some of the polling questions. So what you see on your screen here are the first two questions. So and these are about kind of your knowledge kind of entering into the call today. So concerning your knowledge about provider-based rural health clinics, how knowledgeable do you feel like you are? And concerning your knowledge about how your FLEX program can provide support to those, how knowledgeable do you feel you are? So take a minute, respond to these questions. We appreciate this. And we'll ask you these questions at the closeout of today's call too. Great, thank you. So I think you're all familiar with our organization. If you aren't, though, we're a nonprofit organization, the National Rural Health Resource Center. We're based in Duluth, Minnesota, where it is not the snowstorm we expected today, but we got like a rain and ice storm instead. But regardless of that, we work around the country, and we're dedicated to sustaining and improving healthcare in rural communities. We run a variety of different programs and services here at the center, and one which I already mentioned is TASC, or the Technical Assistance and Services Center, that supports you in your FLEX program work. So we asked some of the state FLEX programs in cooperation with getting information from the reports that you provide to the Federal Office of Rural Health Policy in your mid-year and annual reporting, what state FLEX programs are working with clinics or provider-based rural health clinics. So of the reports that you provided to F4HP, 7 state FLEX programs said that they're providing support to critical access hospitals that own clinics, but not necessarily rural health clinics, 7 of them. And 21 state FLEX programs, so about half of you are providing support to provider-based rural health clinics, and this is kind of the breakdown. So of those 21 states, 18 of them are doing work in finances, 5 are doing some work in quality, 3 in innovative care models, 1 regarding population health, and nobody had reported at that time that they're doing any work related to emergency medical services. So with that, that shows to me that there's certainly more than just three different states on the call today that have information to share about what it is that you're doing. So when we get to that part, or as Nick and Michelle and Stacey and Rebecca are presenting about what it is they're doing, I certainly encourage you to ask questions and chime in about your experiences as well too. We have a lot to learn from each other. So Shannon, could you bring up the next 2 polling questions about kind of what the landscape might look like for RHCs in the different states? Thanks. So these 2 questions, if you could take a second to respond, is about how many rural health clinics are in your state, and then what proportion of the rural health clinics in your state are provider-based. And there's certainly an option to say you're not sure, and that's okay too. Give you another minute or so to respond here, and then I'll kind of summarize what we're seeing. Okay, so it looks like, well, we know there's a whole lot of rural health clinics out there, but it looks like most of your states have more than 50 rural health clinics. So certainly a lot there to cover. And then about 7 of you aren't sure, so certainly something to go back and investigate. And then within the RHCs that are in your state, it looks like, let's see, about 25 to over 50% are provider-based, so about half-ish or so. It looks like most of you don't know what the proportion is. So that's something really important to find out too, because that certainly relates to how your critical access hospitals are interacting with their healthcare system locally, but also how they're thinking about operationalizing the work that they're doing, be it in finance or quality or population health or whatever it might be. That has a lot to do with how they're doing their work. So a big question to go back and find out about. So with that, I think what we'll do is we'll turn it over to hearing from the 3 different states about what it is that they're doing. So I'll kind of introduce them, and what we're going to do is Michelle is going to speak first from Colorado, then Stacy and Rebecca from Oregon, followed by Nick in North Carolina. Their contact information there is showing for you on the screen. And what I've asked each of them to kind of talk about and be prepared to discuss is kind of describe to you what the lay of the land looks like in their state, how many CHs are there, how many rural health clinics are there, and how those are dispersed in their state. Like, are there certain pockets where there's a ton of coverage and pockets where there isn't a lot? Is there some geography that gets in the way, like mountains, for example? Or are they covering certain types of different populations or something like that? So does that have a role to play in access to care? And then to describe some of the initiatives that the FLEX program has worked on with the critical access hospitals and the rural health clinics within their state, particularly anything related to transition value, but also other things. Then they're going to talk a little bit about what some of the needs are that they're hearing from the rural health clinics in their states, but also then the needs that they're hearing about the rural health clinics from the CHs. So what are the CHs telling them that the rural health clinics in the state might need support on? And then lastly, some ideas about how they might be working with them via FLEX in the future. So that's what the plan for content to cover from each of these folks is. So with that, I think, Michelle, I believe I saw your name listed on there. So thanks so much for agreeing to talk about the work that you're doing in Colorado to support the critical access hospitals there. And the rural health clinics. It's *2 to unmute your line. And I think if you can just start with kind of explaining a little bit about what the lay of the land looks like in Colorado, we'd appreciate it.
Yeah, you bet. Thanks, Tracy, for the invitation to come on and speak. So in Colorado, we have around 73% of our land mass is considered rural. So we have 47 of 64 counties that are either rural or frontier, and we're almost completely divided in the amount that are rural and the amount that are frontier in terms of counties. We have 32 critical access hospitals, and interestingly enough, I never thought I would see another conversion to critical access hospital during my time here after kind of the big push, but we've actually had 3 new CAs in the last 4 years, so it's pretty interesting. We've got 48 rural health clinics, and that's federally certified rural health clinics. We have a lot of clinics that are out in rural. We estimate that it's around 112 or so, but that certified number tends to fluctuate a little bit between kind of the lower 40s to, you know, upper 50s type of a thing. It just depends, and sorry, I don't really know why that number fluctuates so much, but it just does. 29 of those 48 federally certified rural health clinics are provider-based clinics, meaning that they're owned and operated by the rural health clinics. But there's another 10 clinics that are critical access hospital also run that aren't certified RHCs. And then we have a pretty good distribution throughout our state of clinics. It used to be that we had a big population kind of down in the southeast part of our state with many clinics, but over the past, you know, I would say 5 or 6 years, we've had greater distribution of those clinics. When we first started working through FLEX with RHC involvement, we started out with a thing that we call a healthy clinic assessment. And really a healthy clinic assessment looks at the daily business operations of a clinic to help them improve their operations as well as the processes within the clinic. So the goals are really to increase that quality of care, increase the clinic efficiency by streamlining those processes and workflow, and then to increase the revenue, therefore strengthening the fiscal stability. So it looks at several different areas like telephone protocol, appointment setting, check-in and check-out procedures, chart encounters, billing, coding, and claims submission, and then days in AR. And so, like I said, all these efforts really are not only benefiting the clinic, but they're also improving the critical access hospital too, and their sources of revenue and the way they're able to help the community. Once we kind of got a good handle on those rural health clinics improving in those areas through the Healthy Clinic Assessment, then we really started to transition those provider-based clinics into our quality improvement efforts that we run through FLEX, which is our Improving Communications and Readmissions project. And so that project works on improving the communications in the transitions of care, as well as the communications between the hospital and the clinic, and then improving the processes and systems to reduce readmissions, especially for like heart failure, pneumonia, and diabetes, and then looking at keeping that readmission rate in that community low. So we have 22 rural counties that are participating in that for a total of 51 rural health facilities, and that includes the CAs and then their provider-based clinics. Other ways we've looked at that too is in addition to those clinical measures that I talked about for the hospital, we have the clinics really looking at their diabetic patients and, you know, how are those diabetic patients have their glucose levels within control. And so this is trying to transition them into doing more of that data collection and then making improvement on that data that they see. And then most recently we've started to engage in creating a patient family engagement councils and helping the clinics to really take that off so they can kind of make that leap more into those population health activities. Some other initiatives that we've done with rural health clinics, not through FLEX, but that we've just engaged in, are oral health, so really helping the clinics by beginning to implement oral health components into their primary care wellness exams, through providing training for fluoride varnish, looking at risk assessments during pediatric wellness exams, discussing individual self-management goals in patients, and then, of course, helping with those PDSA cycles and workflow changes as a part of that. Our state also received a big SIM grant, so that's the State Innovation Model through CMS, and that came through our governor's office, and that was looking at trying to integrate behavioral health and primary care, and really how does that integration look. And so we were able to help the clinics with those efforts too. HIT was also a huge area for our clinics that they were struggling with, so we assisted the clinics with connecting to the Health Information Exchange, or the HIE as you might have heard them called. We do HIPAA risk assessments and then remediation of those issues that's found through the HIPAA assessments, help with meaningful use, including helping to attest to Medicare or Medicaid. And then we do a whole webinar series on presentations, mostly around like rules and regulations and sharing of best practices. We do an electronic health record evaluation and selection, and then provide technical support through like vacation relief and special projects, remote monitoring, and helping set up servers and installation. Some of the other kind of miscellaneous services that we offer are QI trainings, PDSAs, customer service training, workflow, patient cycle time studies, financial feasibility studies, and then of course everything that all of us do, which is answering lots of questions on rules and regulations and providing resources. Some of the big issues and needs that we've heard for clinics are funding, obviously, to support them, very similar to the funding that federally qualified health centers receive. Relaxation of the rules that allow for true integration to happen at the clinic. And then clinics most need help with operations, so more along those lines of financial improvement, sustainability, patient experience, staffing responsibility, development, redesigning workflow, billing and coding. And then in the area of quality improvement, they need a lot of help in coordinated care models, patient and family engagement and education, data collection and analysis and improvement, care transitions and patient navigation, best practices for data reporting, patient risk stratification, establishing referral processes, empanelment, and then under the category of practice transformation, they need help with increasing the patient volume, evaluation of current level of integration and readiness, evaluating out-migration, building stronger referral networks, and then assessment of services that are needed within the community. And one area that I think that Flex could continue to offer help to rural health clinic is through many of those efforts that I just mentioned, including practice transformation, quality improvement, care coordination, population health, and health equity. And that's what I've got.
Thanks. I appreciate that, Michelle. I have a quick question. So that healthy clinic assessment, I like that. That's kind of a neat kind of onboarding tool for you guys to get a good lay of the land. Is that something that you created, or was that a template that was out there on the internet?
Yeah, it was something that we've created. So we worked with somebody very early on, especially in the area of like accounts payable and receivable and things of that nature. But yeah, we've just built it over time, so we've been able to get some grants to do that, and it's been very helpful. You can just keep kind of continuing to add to it.
Sure. And do you have for next year any specific projects that you're thinking of so far, or are you still working to figure that out?
Well, that's a great question. We're still working to try to figure that out. We definitely really want to focus on rural sustainability and how might we be able to assist the hospitals and their clinics in that area, but not having so much fatigue for them. So we're going to be sunsetting our eye care program after Flex ends, and then we have another grant that ends in February of 2020 that helps support those efforts for rural health clinics, and we'll be ending that and trying to guise everything under that rural sustainability. And we're hoping to do kind of like mini rapid cycle improvement projects under that, again, to help with that project fatigue that both the clinics and the hospitals are experiencing.
Sure, yeah, that's a great idea, though. Those rapid cycle things are quick and they go a long way. And yeah, from my experience, too, they've just been good. They're just a good learning opportunity for the facilities to see that you can do something short that is sustainable, and then they can take those methods and go forth and prosper and do other things with it, too, which is great.
Yeah.
That's interesting that you're sunsetting eye care, too. You guys have been doing that a long time.
I know. It's kind of like happy and sad at the same time.
Sure. Yep. Yeah. That's good. Does anybody else have any questions or comments for Michelle? Again, you can use the chat box, or it's *2 to unmute your line. Okay. Well, thanks, Michelle. And if something comes up, please stick on the line here.
Great. Thanks.
So I'd like to invite then Stacy and Rebecca to, again, unmute your line by pressing *2. And you have presenter rights as well, too. So as Shannon's pulling up the slide set here, down in the left corner of your screen, you will see right and left arrows, which will advance your slides for you. So go ahead and take it away. Thanks so much for being here.
Thank you, Tracy.
Thanks for having us.
Can you guys hear me okay? This is Stacy.
Yep, I could hear you both.
Okay, perfect. So this is Stacy Rothwell, and I am presenting today with Rebecca Dilbert. We're both from the Oregon Office of Rural Health. Both program managers, our primary work here in our office is surrounding the FLEX program, but both of us also provide support and technical assistance to all of the rural health clinics across Oregon, whether they're hospital-owned or independent. So, Rebecca, you've got control. I'll let you go to the next slide.
Yeah, there you go.
Perfect. So we just wanted to give a little bit of an overview of what Oregon looks like. We've got 25 critical access hospitals here in our state. As of November, we have 94 rural health clinics. Of those, to kind of break it down a little bit, 41 of them are critical access hospital owned. And to take it a step further, 23 of those 41 are owned by system cause, and 18 of them are independent. And this is just a map to kind of show you the landscape, give you a little bit of a visual. So the critical access hospital. Can you hear me?
Hello?
Hello? I still hear you. Okay, good.
Okay.
I just got this hold signal, so I wasn't sure. Okay, so on this map, the circle with the little legs, that represents all of the critical access hospitals across our state. The red dots with the numbers in them show the number of critical access owned rural health clinics that are certified rural health clinics. Some communities obviously have more than one. And then the black dot with the number represents independent rural health clinics or PPS, hospital-owned provider-based clinics. So it does show we have a great representation of clinics and hospitals along the western side of the state and the northern side of the state. It does look quite sparse in the center and along the eastern side, but it's not as bad as it looks. So pretty much the entire eastern side of our state is frontier. It's got a huge geographical footprint, and it's a couple hours between many of the towns out there. So I do feel like we're pretty well represented with critical access hospitals and rural health clinics along the eastern side of the state. It just doesn't look so when you're looking at a map. And then, of course, in the center part of the state, the Deschutes County and the Klamath County, those counties have some larger metropolitan areas in there. So as far as rural health clinics and critical access hospitals, they wouldn't be located in those areas. So that kind of gives you a picture of like what it looks like out here in Oregon.
Yeah, and like Colorado, Oregon is majority rural, our geographic area, with 10 of our 36 counties being frontier, so you can see that represented on the map. So previously, the Oregon Office of Rural Health support to RHCs historically was provided by one staff member at less than 0.25 FTE, and they would do all of the general technical assistance surrounding compliance and billing, mock surveys and assessments, and we continue to do this. They do the mock surveys and assessments. RHC workshop is part of the annual Rural Health Conference, which we host. We have seen a jump in RHCs across the state by about 30% in the last 3 years. So that spurred us here at the office to recognize that need for co-owned RHC support under the FLEX grant, and we reinvigorated our staff FTE to provide technical assistance once again. As I said, just one staff member at less than 0.25 time really wasn't going to be able to meet the need. And in late 2018, we surveyed the RHCs to assess needs for fiscal year 19 and going forward in further recognition of that increased need and an increase in RHCs across the state. One of the things that we'd already been doing that we were as we recognized this need was I managed the Small Rural Hospital Improvement Grant Program for the office, and in 2017 I had SHIP eligible hospitals start requesting funding for work at their provider-based RHCs. I should say that we have 25 critical access hospitals, and we usually have a minimum of, all of them are SHIP eligible, and we usually have a minimum of about 20 of them participating. And they started to request to fund projects under SHIP at their RHCs. They wanted to start, most specifically, we had a few that came out asking for CDCAPs. Initially, that was not part of the SHIP program. It was hospital specific, but in recognition of that, we tried to address the need. We were able initially to align some CRACP training that we were providing to the hospitals under the FLEX program. We were able to work with the vendor for that and tailor a program for SHIP to complement quality work in both settings for the critical access owned hospitals and their provider-based clinics, while of course remaining appropriate to the funding priorities for SHIP and for FLEX. And we took that increased desire for programming at the clinics and provided feedback in the SHIP progress reporting, and now the SHIP menu includes a value-based purchasing clinic quality measures training option, and right away for fiscal year 19, 24% of our applicants proposed projects in that category, so it reinforced our understanding of that need. So we're going to also continue to seek ways to align our provider-based RHC work under the SHIP and FLEX programs, because having those complementary programs actually was fairly beneficial and highly valued. Hello?
Okay, sorry about that. I have my line on mute.
Oh.
So to talk about a little bit more about what we're doing with the fiscal year 18 FLEX activities as they pertain to rural health clinics here in Oregon. As Rebecca mentioned, we did a CAW-owned RHC financial and operational needs assessment, and we built that as a survey monkey that went out in late November, early December, and we've had a pretty good response rate from clinics on that. We do have some stragglers out there that we intend to probably make site visits or telephone calls to go through the assessment to get the information. We really want 100% participation so we can get a really good picture of what the needs are out there for the clinics moving forward. So we've also built in some Medicaid cost report training to provide to RHCs. What we've found from working with our state Medicaid office is that not all of the clinics in Oregon, for whatever reason, are not always filing their state cost reports. Sometimes it's staff changing within their clinic, and so they just don't have anybody that knows how to do it. And also sometimes they just don't have a huge Medicaid population, so they don't really feel like it's worth their time to file the reports. So we just identified the need to do some ongoing training for the clinics so that they understand the process and what it takes to file those reports, and that they can file them and get the money that they have coming to them. Another activity that we're doing this year is some emergency preparedness training. We're working with Kate Hill over at the compliance team to do some webinar-based training for the provider-based rural health clinics across the state, just to make sure that they're in compliance with those new regulations that went into place this last, not last November, but the year before. We've got some scholarships worked into our FLEX grant this year to provide to clinic managers or administrators. Specifically this year we're sending them to a Northwest Rural Health Conference that's a regional conference that typically Washington, Idaho, and Oregon work together to provide. And then we provided some practice innovation grants this year. We did 4 grants at $5,000 apiece to help clinics build innovative models within. We've left it up to the clinics to propose what they wanted to do, and like an example of one of the grants that we've awarded, they were implementing a diabetes prevention program within their clinic. And then part of the work that we're doing this year too is evaluating our internal office's ability to support rural health clinics to converting over to the advanced care payment model. So the ACPM is a APM model that was developed by the Oregon Health Authority for on the Medicaid side. And currently, our Oregon Primary Care Association provides support to FQHCs in Oregon to participate in this program, but there's not any support for rural health clinics that are operating at that higher level to be able to participate in that. So we're evaluating what it would take to be able to provide the support to the hospital or to the clinics to participate in that program, and if our office has the manpower to do that. So we're looking at that. And then, of course, as Rebecca mentioned, we'll continue to do our mock site surveys. We'll go on site to clinics that are existing, and they might be expecting a surveyor to show up anytime, so we help them make sure that they're in compliance. And then we also provide that service to clinics who are converting over to RHCs as well. And then obviously as well, we will continue to provide our annual rural health clinic workshop as a component. It's a pre-work or a pre-conference workshop at our annual Oregon Rural Health Conference each year.
Okay, and we pulled out some of the assessment highlights from the RHC assessment that we just sent out at the end of the year. The clinics reported their top challenges and needs. There's some pretty usual suspects: provider and staff recruitment and retention, no-shows, patient compliance, provider and staff engagement, quality reporting, lack of space, cost of equipment needed to practice, and leadership and staff training opportunities. And that one was interesting because they identified also, many of them, customer service training opportunities. So we had previously fielded lots of leadership and board training requests like that, but that was an interesting one. The top reported challenges and needs for patients were lack of mental health and addiction therapy. Again, pretty usual suspects, and we have had that reinforced with our Rural and Frontier Listening Tour site visits in the last couple of years. Access to care when patients want it, access to specialty care and transportation, and lack of retail pharmacy services. And the top reported clinic strengths, self-reported, were employee and provider engagement and commitment, high level of care provided to the community, access to care, having newer facilities, and their patient-centered primary care home status. So it's interesting to see where they align and where they differ. And I think that it's an interesting thing. Again, we did our listening tour and other programming, the identification of things like lack of mental health and addiction therapy, transportation, pharmacy services in our rural and frontier areas. We're starting to see we do have reported social determinants and kind of economic development issues that lead in to providing care.
So as we look at fiscal year 19 and beyond and the flex support that we're looking at providing, obviously we don't have all of the details because we're obviously still working on those as we prepare for the notice of funding opportunity to come out, but kind of just some high-level overviews of what we're planning under Flex is continued leadership and staff training opportunities. Some examples based on feedback that we've gotten from hospitals and from clinics is board training opportunities, customer service training, as Rebecca mentioned, and then more leadership opportunities for clinic management and administrators. Ongoing assessment and support, that's not something that we're just doing this year. As I had mentioned in the previous slide, we're looking at our ability to be able to provide that support internally here, but we're also working with clinics to kind of assess their readiness as well. They need to be practicing at a pretty high level in order to be able to participate in that alternative payment model from our Medicaid office. So we'll be looking at that moving ahead as well. And then scholarships for regional and national conferences. I don't know if any of you guys follow the NARHC listserv, the National Association of Rural Health Clinics listserv. Just, I think it was last week, there was a bunch of posts pertaining to clinic managers seeking the Certified Rural Health Clinic Professional certification. And basically what the conversation was is that it was hard for clinics to be able to budget for the managers to attend the national conferences in, usually it's like, I think, Indianapolis and then in San Antonio. This last year, their fall conference was in Tahoe. So it's hard for them to budget for those expenses to go to those conferences and make it a priority for them. So that's something that we were considering offering as a scholarship to that conference and maybe some support to help some of the clinic administrators or managers in receiving that training and that certification. And then continued grant opportunities, like our innovation grant that we've offered. And then also just continuing to work to identify partners within our state that we can align with to strengthen the services that we're providing to the RHC community. Rebecca, did you have anything to add to any of that?
No, that's pretty, I actually did part of our assessment for the CRACP training. I completed the training this past fall. Got a lot of value out of it, and talked with the Oregon folks who also completed the certification, and they reported high value. So that was one of the reasons we were exploring it. But again, seeing they have a hard time budgeting for the travel that's required for the certification, and I know that that's under discussion. What will be needed to continue it. Yeah, and one of the things that Oregon is lacking is we don't have a statewide RHC association, and so that's come up as part of our RHC technical assistance is do we have the capacity and can we help create an association, which we think would be pretty beneficial, but the logistics has been ongoing discussion.
And one thing too, just to add, is something that as we're especially looking forward or looking ahead at this fiscal year 19 and beyond, and doing these assessments with the rural health clinics, one thing to keep in mind for other states as well is in Oregon, and I should have put it in the previous slide when I kind of gave that breakdown of rural health clinics. You know, we've got, I think it's either 6 or 8 owned clinics that are not rural health clinics, so they're just provider-based clinics. Yeah, so just, I mean, that's something for other states to keep in mind as if you are providing programming and support, is to also make sure that if that's an area that you want to support as well, that you identify that, I guess. Because if you're just saying provider-based rural health clinics, then typically you're looking at your certified rural health clinics, but there are also opportunities to support non-rural health clinics that are owned by cause as well. So that's it. Here's our contact information if anybody is interested or wants to reach out to us.
Excellent. Thank you so much, Stacey and Rebecca, for sharing that. I personally found it really exciting to hear about how you're leveraging flex and shift. That was probably not surprised to hear me say that, but I think that's tremendous, and I think you know, that you were doing exactly what you needed to do, and if you couldn't support CDCAPs per se through it, you were thinking very creatively about how to leverage one thing with another. So that's fantastic. Does anybody have any questions for Stacey or Rebecca? Okay. Again, if you do, you can use the chat box. Otherwise, right now, I think maybe we'll move into hearing from Nick Galvez from North Carolina, who's going to kind of share the story about the rural health clinics and how they work with the critical access hospitals in the state of North Carolina. Thanks, Nick, for joining us. It's *2 to unmute your line. Again, Nick, it's *2 to unmute.
Can you hear me now?
Sure can, yep.
Okay. I apologize for the slides there. They look a little bit blurry. That's probably the format in which I sent it over. But I'll try not to focus on the words of the map, but more the big picture. So in the state of North Carolina, we have 20 critical access hospitals. And just for a point of reference, we have 70 counties that are considered rural counties. So you talked a little bit, or Tracy, you mentioned kind of the layout physically of the state. And over on the west side of the state, or the left side, we do have some mountains there that really kind of separate 2/3 of the state from the other third. And that's probably one of the reasons that we have 10 of our critical access hospitals on the left side or the west side of the state, because there's really very little access to get there, and it takes you know, a very treacherous up and down winding road to get to those hospitals, and therefore there's not any major metropolitans. The only exception to that would be the 3 gray counties you see there on the left. That's where Asheville is. So there's a pretty big congregation of you know, some urban counties there, but other than that, all those counties are pretty rural. Do I have the ability to move the slides?
Yep, you sure do in the bottom left.
Got it.
Some arrows.
Yeah.
Yep.
So one thing that I think is a little different about North Carolina is that we have state-designated rural health centers. And the state, our office designates some of these rural health centers as a state-designated center. And if they have that designation with us, then they can get funds from the state. So these are not the provider base. These are all independently, not with a provider. And also they're non-for-profit, and they have to serve a certain amount of the community. So that's kind of a separate rural health center program that we operate within our office. And I'll just mention a couple of programs they work on there because it relates to the provider-based rural health clinics. They have a medical access plan in which we'll pay for residents of the county that can access the rural health clinic and get their visits paid for. There's some capital funding that is supported as well by the state. And that's about $2.7 to $3 million per year they get from the state. And I've been working closely with our rural health state designated managers so we can kind of overlap with the critical access hospitals. And again, that's in 36 counties. So if you look at the big picture of the rural health centers, we have a total of 87 that are in the state in 38 counties. And in the middle of the state is where there's a major highway. So where you see that kind of gray line right through the middle and it goes towards the west side is basically a major freeway where there's a lot of population density. So when you talk about the rural, the provider-based rural clinics with the critical access hospitals, we have, of the 20 critical access hospitals, 10 of those, or about half, have provider-based clinics. We have another 3 that are planning to open within the next 6 to 12 months. And then we have 7 hospitals that have said no, they're not, or they had in the past, and they're not currently, and they have no plans to open up any provider-based clinics. So when you look at how the clinics are dispensed throughout the state, obviously the majority of them are in the rural counties. And this is the part where it gets really blurry because if you look at the slide there, it does mention how many rural health clinics are in each one of those counties. So we have some counties that have as many as 9 rural health clinics. If you don't see a number, which may just be a blurred number, then it means they just have 1 rural health clinic that is either state designated or a CMS certified clinic. So some of the initiatives that we have worked on in the past, and I've been in my position for only about 6 months, so some of these I'm currently working on. Some have been worked on before I came on. We've done some finance and operations consultations with some of the critical access hospitals, and inevitably when we do that, we do delve into the provider-based clinics if they have one. If they do not have one, then inevitably the consultants will suggest if you were to open a provider-based clinic, this is the financial upside that you may see, and this is how much it would cost to run the clinic. We've also done some quality improvement projects with some of the critical access hospitals that would just indirectly include the provider-based clinics, the RHCs. And currently one of the projects I'm working on now, and I'll go back because we're working with one of our state-designated rural health clinics in Clay County. We actually just started the EMS paramedicine sustainability grant, and we're working with the state-designated rural health clinic to base the paramedicine program out of. And they will be working with Clay County EMS to try to manage high utilizers of the emergency room, chronic 911 callers or use of the system, and any other clinical needs. We're still in the process of trying to determine what's going to be the focus, but it will probably be one of those three focuses. So some of the big needs that we've heard from our rural health clinics, when I've been out to visit some of the critical access hospitals and I've talked to the clinics, they are asking about staffing, loan repayment, and specialist providers that could come because they just can't get the staff, and that's not really unique to provider-based clinics, or it's more of a rural type issue or concern. Some of the needs for the provider-based clinics and the cause, again, just with staffing, trying to be able to get primary care providers in the clinic as well as specialists in the clinic. Some of the things that I would like for us to work on for the next year with our rural health clinics is their use of telehealth. Our office is really trying to encourage and support really all of our safety net providers on the use of telehealth. We do know that it's costly, but we also know that it will save on patient care. It'll improve quality, but they need some support to try to get those systems in place. Also, we would like to work on chronic care management and or remote patient monitoring with some of our rural health clinics. We think, again, that's going to be something that's key with value-based care. And then finally, we want to continue our work with paramedicine and EMS and just trying to make sure that those two systems are working with either the hospitals or the health departments or the county to help keep patients out of hospitals if they don't necessarily need to be there. And that's it for me. Any questions?
Thanks, Nick, for explaining that. I'd like to hearing not only the the past history of your program with doing financial and operational type work, which I said earlier at the call. If you don't know what proportion of your critical access hospitals own clinics, it's very, very important. So certainly figure that out because it's very related to their finances. But I'd like to how you were saying some of the work that you've been doing about paramedicine, and I know your programs are doing work with telemedicine too, but your future initiatives that are involving things that are related to population health with, expanding maybe the paramedicine or telemedicine type work, but also those things, chronic care management and remote patient monitoring and stuff like that too, which is pretty fantastic. Any questions at all for Nick about the work that they're doing there in North Carolina? Again, star 2 or use the chat box. Okay, so interesting to hear. I think 3 different programs here. that we asked to present, and honestly, leading into it, I knew you were doing some work about rural health clinics, but didn't exactly know the details about it, and kind of some similarities, but some differences too in the work that you're doing to meet the needs for the CHs and the provider-based RHCs in your state, or the other clinics too. So I know we're kind of nearing the end of our time together. We did have a couple other questions we wanted to ask you. So there's two more polling questions here, and this just kind of, I think, is kind of good food for thought. So the first question is, what program areas has your FLEX program supported in the past? And I don't know if you can provide more than one answer to that question, Shannon. I don't know if you know the answer to that.
They can only provide one for that question.
Okay, all right. So I guess if you're doing a variety of different things, pick the one that's been the majority of your work, I suppose. So just for curiosity's sake, where your program maybe has supported rural health clinics in the past. And then the next polling question over is kind of an open text field about what some of the biggest needs are that you're hearing from the rural health clinics in your state, and maybe things particularly that you're thinking about supporting with FLEX in the coming future, or a different program like SHIP. So what are some of the big needs that you're hearing from the RHCs in your state? Okay, and it looks like please keep typing as I'm kind of summarizing here, but looks like for those that have responded to the question about what your programs worked on in the past, maybe most either haven't supported them or have done work with quality improvement or financial and operational improvement, and maybe one with some EMS and one in an other type area. Some of those needs that you're hearing about regulatory barriers, certainly something that some of you have talked about on the call today. Michelle was saying, of course, we just field any of the TA questions that come in too. And quite a few comments here about workforce, whether it be recruitment and retention or training, and how to get them and keep them there. Reimbursement reform is impacting all of our facilities. Billing and coding education to reduce those denials, which goes along with the cost reports and some of the regulatory support with those things, some practice redesign. So yeah, excellent. Those are important needs. I think we've heard some of those things mentioned from the folks here that shared their stories today too. So I encourage you all, as we kind of round out the day here, or our call together, is to reach out to those that shared the work that they're doing, and certainly start to think about some of your neighboring programs to your states, or programs that you maybe reach out to often, just have some common similarities with, and pick up the phone and ask them about how they might be working with their RHCs too, how they might be leveraging FLEX or SHIP or other programs, state-based programs as well, to support those, because there's always lots we can learn from each other. So as we close out the day today here, a couple more polling questions. We appreciate you taking a minute to finish these. So the first two questions are similar to the beginning of the call about your knowledge level about provider-based rural health clinics and opportunities to provide them with some support. And then one final closeout question about your satisfaction with today's call. And as you fill in those, a couple reminders. We're anticipating the notice of funding opportunity for the FLEX will come out at any time. We have the NOFO, the Notice of Funding Opportunity webinar, scheduled for a week from today at 1 p.m. Central Time, which F4HP will be leading, and that's kind of a technical assistance overview of what the NOFO contains. So hold that date still. We're still planning on keeping that and hoping that the NOFO is released in the interim. There is another technical assistance call planned for January 17th about the FLEX EMS competitive supplement that will also be coming out, so hold that date. We have a Task 90 call scheduled for February 13th in the afternoon. The topic for that is about